Welcome back, everybody. Here we are again with part 2 of lab tests. So everyone requested that Colton and I continue with how to read your blood work, right? What's going on, Colton? How you doing?
Not too much, man. How are you?
I'm good. So I think
Good.
we left off with, we start with liver function, I guess.
Yeah.
Right? Some important stuff we see as bodybuilders a lot.
Right. We talked about ALT and AST last time, but that was just sort of the surface level stuff. And I mean, those are technically more of muscle wasting byproducts than anything else. But the ALP is one that we didn't discuss.
Yeah, I mean, so ALP is just an enzyme similar to the others that's released by blood, bone, and liver. And there's actually an ALP receptor on most parts of the body, unlike ALT and AST. So it actually tells us a little more. A higher level can be a sign that there's liver or bone problems. It's used to detect other things. A higher level can also mean that you're deficient in magnesium. So it's another good way, for us to look at someone's magnesium status without looking at something like MHC. Kind of gives you a more exact thing. So I actually had to change my magnesium status because my other markers were fine, but it turned out my ALP was off. And Dr. Dean showed me this, and we raised mine. And sure enough, it actually improved my sleep even further. So he was
awesome.
Totally right about that.
That's awesome. Yeah, I think it's funny. Little fun fact about ALP is alkaline phosphatase is actually used in dairy for successful pasteurization. It's like how you pasteurize milk. So I don't know if anyone really cares about that, but I think it's interesting.
Then we'd have albumin, I guess, would be next, right? So it's just a protein in the blood, but it's relevant to us because it's one of the things that carries testosterone around in our blood, and it would be considered. We can touch on testosterone at the end of the video, but it would be the testosterone that's bound to that would be considered bioavailable, technically, right? I don't know if that's. I think some of the thought process on these things is changing, but that's at least.
I mean, that's how I understand it, right? I think it's
loosely bound.
One is the most abundant protein in blood plasma, and it's what is responsible for carrying most of those byproducts, metabolites, and hormones around. Especially drug transport too, as well. Yeah.
And what's interesting though is where it changes not so much in the albumin view. I think it changed in the sex hormone binding globulin view, right? Because the classic sense says that sex hormone binding globulin testosterone is not available and it's firmly bound and can't be used. And we know that that's not necessarily the case, and that sex hormone binding globulin on its own has a receptor and can transport things as well, depending on what it is. It renders DHT completely useless, but testosterone actually can be transported actively to some degree with it. So, we're learning more and more. And there's other stuff like bilirubin and total protein. I think one of the more interesting things is GGT. I think a lot of people asked about that last time in the video.
Yeah, GGT is, I think, the one that bodybuilders should be paying most attention to, just because ALT, AST can be so varied depending on whether you trained or did cardio or you're eating high protein diet and all those kind of things. But I think GGT is unique because it's an enzyme found in it's the same as the others, right? And as far as being a transaminase, but it has a much higher concentration within the liver and biliary system. And it, I think, therefore kind of plays a more significant role into being more exact about whether your liver function might be impaired or not.
Yeah, where ALT and AST, at least in our population, you almost never see it not elevated to some degree.
Yeah.
Right. There's a clear difference. Now, I think the problem with the ALT and the AST is the range is skewed. It's like an old, outdated range for people that didn't exercise. So it probably should be higher, because liver failure generally is severely elevated ALT and AST, like in the thousands. Like I saw one, the guy was in the 2000s. ALT.
Holy fuck.
For a transplant. So like clearly like total liver failure, but not anywhere near. If you or I go to the doctor and you're like 60, your doctor's like,
oh no. What do you know how to? Interesting question for you, because honestly, I read all day. I don't speak all day. So when I read things like GGT and I see how it's spelled, I try to pronounce it. How do you pronounce it? Because I say I don't even want to try gamma glutamyl transferase. Is that correct, or is that completely
transferase? Yeah. Yep.
Okay.
That's how I would pronounce it.
Okay. Cool. I don't know, because you
Because
never
you're
hear like
GGT anyway.
yeah.
So then there's other random ones like LDH and stuff, but I don't think that those are not as common. Like I think most bodybuilders, I think the point with GGT is if you're concerned with your liver, if you're using oral steroids or anything of the sort, if you're drinking alcohol, using over-the-counter pain medicine,
don't
like
do that.
Tylenol specifically, GGT is something that I would have checked, even though some doctors don't know about it, but it's something that's worth looking at over ALT and AST.
I think it should be on a standard lab draw for most bodybuilders, and it also plays a really important role in the metabolism of glutathione, which I think is important too, because if it's extremely high and you're just ripping up all that glutathione, you could see potential reflections of that in other markers as well, like inflammation and such. So
cystatin C probably is going to be elevated. This is going to be other.
And another side note, it is very correlated with fatty liver disease, unlike ALT, AST. If you have chronically elevated GGT that doesn't seem to come back down, there's a very high likelihood that you have fatty liver disease, which is a big concern for bodybuilders, just because testosterone and other derivatives are causing volume increases within liver and kidneys and such like that, and as well with the amount of food that we eat. It's probably a good idea to check this.
Yeah. So then after that, really, I guess the next thing that seems somewhat relevant to our community would be thyroid function. So this is where it gets kind of, I think, in the weeds, right? So the average doctor is going to look at, if they're even looking at thyroid, they're going to look at TSH, and most of them will stop at TSH.
Yeah.
And again, I get it. Doctors are taught to not, they don't want to find something actionable because then they need to act on it. If they find something wrong, it's out of what they're then responsible for it. So a lot of times they'll just look at TSH. And then because it has such a broad range and it doesn't really show us much, it generally is a great way just to kind of check up without really seeing what's going on, right? I'm never comfortable making diagnosis just looking at TSH, unless it's very skewed, but I would still want to see other markers because I want to know why it's skewed.
Right.
And the range is 0.4 to 4. The 4 is way too high. 0.4 is way too low. I find like 0.8 to 0.9 seems to be about ideal for most men. Maybe a 1, like you want it like around 1, slightly lower maybe.
The higher it is, the greater the risk for thyroid cancers, essentially, and we obviously want to avoid that. I think of the best functioning, or I should say the best, because that's not necessarily true as a functioning whole, but the best system, I guess, as a thyroid system would have, kind of around that level of TSH that you marked. And then if it's higher, you would want to do more in-depth lab work. And if it's lower, you'd want to do more in-depth lab work. But it's a good sort of test to see, hey, is there anything I need to be concerned about here as far as like underactive or overactive thyroid?
So it's the only thyroid hormone that, at least that we're going to discuss, that's really not just secreted by the thyroid. It's basically a signal to the thyroid. It's like a volume control. It's basically how, it's telling your thyroid to turn the volume up or volume down, depending on how the thyroid's responding. So obviously, like you said, if it's around 4, it means the volume's loud because the thyroid's not doing anything, right? And if it's low, it means the thyroid's overproducing, most likely. And we want to know why it's doing one of the two, because neither is good. After that would be free T4 and T3. So for me, when I look at T4, I'm generally not that concerned unless it's really skewed, because T4 to me is like the idle in the car. So it's kind of set from, let's say, from the factory in a car, from your birth, and it's basically just your baseline, and it's not super. I want to say it's not super important. It doesn't really tell us a ton because it's not active. What you care about is the T3, basically. So just bringing T4 up doesn't necessarily mean it's going to all convert, right? There's other things that have to go on in order to have that conversion. Even silly things like iodine and selenium need to be present.
Yeah, exactly.
And then obviously free T3. So free T3 is basically going to tell us what your thyroid is actually doing, right? That's basically the speed at which your metabolism, that part of your metabolism, is running. I think the most interesting one that I like to see that you rarely see on labs, unless an endocrinologist does it or you request it, is reverse T3, because that tells us the other half of the story. Because if you don't, that's basically the inactive version of T3. And you see that generally in 2 situations. with bodybuilders, you see it from over dieting, and you also see it sometimes when people are ill. So when we're sick and your body's trying to save energy to repair itself, it'll up the reverse T3 to slow its metabolism down. And also when you over diet, if you see a bodybuilder that's chronically dieting or at the end of a show prep, reverse T3 tends to be high. You can usually reverse that by bringing the food up.
Mm.
And
Yeah,
another thing
I think just real quick, I think reverse T3 and T3 is a really, really good proxy to understand which deodolinase enzyme might be influenced by your current lifestyle or situation. There's a lot of things that can influence those enzymes. So that's not something we can necessarily cover in this podcast, but it's
we could probably do a whole video just on thyroid.
Yeah, it's just on deodolinase enzymes, for Christ's sakes. There's
months. It's probably make months of videos just on the thyroid. Something else, and just another basic just overview so people understand. Thyroid issues are generally not seen in men. They're not as common in men. They're more common in women because estrogen has a large effect on your thyroid function, much larger than testosterone. You do see with TSH, an interesting thing is sometimes when men have low testosterone, and even if you're not testing their actual testosterone levels, you'll see TSH is elevated and cholesterol is generally high as well too. When those two things occur, generally I'd like to see a total testosterone measurement because that generally is going to dictate why the thyroid is doing that as well. You see one of the reasons why you see thyroid disease in women more than men is because of estrogen. So again, not to harp on this, but with the new trends of the running the estrogen really high, you're going to see more thyroid issues because the higher the E2, the more bound up thyroid is going to get. So after that, I think cholesterol, which is like everyone's.
Do you want to talk about just really quick? I mean, I don't think many people actually address it, but like thyroid binding globulins and thyroid antibodies. Or sorry, not
sure. We can touch on them. You can go ahead if you want.
Yeah, I mean, I think it might be something that is important, right? If you have an elevated TSH or a low TSH, and you're like, okay, I need to do further testing. What do I need to do? Reverse T3, T3, and T4 will tell you a lot, but sometimes it could be an autoimmune disease. And if you see white blood cell elevation in conjunction with thyroid dysfunction, you might want to get your antibodies tested, and that's just because there's anti-thyroid peroxidase, and then there's anti-thyroid globulin, and those are really important to understand. Essentially, if you have potential Hashimoto's or Graves' disease or any sort of antibodies that are effectively attacking your thyroid, and I think what's really important is to understand that can also be treated like completely naturally. Sometimes it's just some lifestyle habits. Smoking often can cause things like that to happen. But that one's an important one too, I think, worth mentioning.
Yeah. Thyroid binding globulin is basically similar to sex hormone binding globulin. Most hormones need some sort of carrier protein, and it's either going to assist them or it's going to render them useless, depending on what you're looking at, right? And one of the uses, one of the less known uses of a drug like oxandrolone or Anavar is that it reduces thyroid hormone binding globulin to some degree. How extreme, I don't know, but it is a tool that bodybuilders will sometimes employ to kind of free up more thyroid hormone at the end of a diet. It's the only anabolic steroid that I know that has any effect on that, like directly.
So do I.
Cholesterol. So I feel like very rarely do you see people with good cholesterol in America. But a lot of times it's not necessarily that bad, right? Like they're considered independent risk factors for a cardiovascular event, but it's kind of the whole picture that I would look at versus just,
Yeah. And I get really passionate about lipidology in general, but I think cholesterol is one of the things that you probably don't need to worry about too much. Instead, I would rather look elsewhere to make sure your cardiovascular disease risk is low or minimized. And cholesterol is great for other things, I think, like insulin sensitivity and various other components of the healthy system. But a lot of people, I think, conflate that like dietary cholesterol is what manipulates cholesterol. And that's not necessarily the case. It's more so what you are doing to your body that's manipulating cholesterol. And then furthermore, cholesterol can't just freely transport itself through your blood. So if you have elevated cholesterol, that's one thing, but having, for example, lipoproteins, which do transport those fat molecules to locations, or not, and then they detonated your, blood, causing foam cell creation, all that stuff. But the idea that cholesterol in and of itself is bad isn't necessarily true, because cholesterol doesn't just go through our body. It needs a lipoprotein to carry it around, and that's why we test for lipoproteins, because that would be more predictive of certain cardiovascular events.
Yeah. So, for just for the basic overview, so there's LDL and there's HDL, the two standard, right? There's also VLDL. It's basically LDL is considered the bad and HDL is considered the good, but like we just discussed, that's not necessarily the case. LDL is basically what should be headed, out, and HDL should be going in. The liver is basically where a lot of this is controlled. And cholesterol, like you said, you would die if you had no cholesterol. Cholesterol is also the foundation of all steroid hormones. So without cholesterol
and all cells, I mean, it's in every
cell membrane is negative. Yeah. So you would die without cholesterol. And like you said, so eating an egg yolk necessarily doesn't raise your serum cholesterol. It's not so much a factor that.
Right.
Saturated fat does have an effect on it, and simple sugars can have an effect on it, and lifestyle things like cardiovascular health, right? Dietary fiber, hormones, estrogen has, an effect in this. Androgens have an effect the opposite. So androgens stimulate an enzyme in the liver that cause an excretion faster of HDL. So you lose, and that's why people on steroids, their HDL is generally lower, because we're losing HDL at a faster rate than you would be producing. And
as well as it reduces LDL receptors. So then you get,
more. And so, so cholesterol's just part of the story. And then, triglycerides. Triglycerides to me are slightly more dangerous.
Yeah.
When they're
I think those are much more important in terms of what's, like a serious issue. If your triglycerides are highly elevated, that's something that I'm like, hey, dude, like we gotta make some fucking changes big time.
Yeah. And that's unfortunate that the majority of that is from lifestyle stuff. So at least you generally can change that. And that's kind of the beginning of metabolic syndrome too. Like you don't want to see that with glucose, right? When glucose gets elevated, triglycerides get elevated, there's a problem down the road relatively soon.
It's a huge problem. If you're, I think what's really cool is triglycerides are almost a proxy to further test insulin resistance. Like if they are elevated in conjunction with something like a blood glucose or a fasting insulin, like you can rest assured you're likely having some form of insulin resistance.
Yeah. And we can also we could probably do another test on some of the more specific ones. So I think guidance like insulin, like the insulin test and stuff, we could probably do a video separate on some of those extra markers, because again, those aren't as common in blood work, and I don't think everyone needs it. But if you have some of these other things elevated, it's worth looking at. And then obviously total cholesterol. So a lot of doctors will then look at the ratio between the two, which the ratio is almost more important than each individual number. Do you want to talk about ApoB?
Yeah, I think it's important. I think it's really important. Apolipoprotein B would be what you consider, and this is lipidology gets very confusing. So there's apolipoprotein B, apolipoprotein B100. There's little a lipoprotein and big A. They all have different things. Some of them are talking about genetics. Some of them are actually molecules in our blood. But apolipoprotein B is really important because that is the atherogenic molecule when it comes to cardiovascular disease. That is the molecule that will produce foam cells, that will actually get stuck into your endothelial wall and cause malignant growth of some issue, scar tissue, whatever. And it's truly not even really known what it's exactly doing to cause or stimulate cardiovascular disease. It could be foam cells, it could be many different things, but rest assured it does produce some effects. And so usually what you want to see is at least below 80 milligrams per. And the idea there is that, again, like I was mentioning, cholesterol is one thing, HDL and LDL are one thing. I don't really think HDL and LDL are super useful because at the end of the day, it's just a cholesterol measurement. HDL-C and LDL-C doesn't exist in the body. It's just a calculation. What does exist is lipoproteins. And so if we can actually test the lipoprotein that makes up low density lipoproteins, which is lipoprotein B, then you have sort of more of a configuration to triangulate, hey, this is a fucking problem and I need to address it, because above an 80, you're at high risk. So I usually try to keep it lower. And that's done for most part, the basics, physical activity, a good diet, right? I think these things are understated but over important, and most people fuck them up in the first place. But beyond that, what I usually do for bodybuilders that struggle is have either infrequent dosed statins, but like very infrequently dosed, or ezetimibe. So
Yep. And just going back to cholesterol real fast, I personally don't freak out unless I see HDL very low, single digits, or LDL very high. Right? If it's
HDL is a really good proxy. I think it's a really good proxy for like general well-being in a circulatory term, right? It doesn't give you an exact picture, but it will let you know, similar to the other things that we've mentioned here, like TSH. It'll let you know. It's the canary in the coal mine. It'll let you know if something's going on.
things wrong, yeah, and you can further look. So with that, we can do. I'm trying to think of what else would be common on blood work. C-reactive protein. Oh, with that, oxidative stress also plays a large role with triglycerides and with cholesterol. It's very likely that oxidative stress is actually what's causing a lot of the damage that cholesterol causes. It's actually not the cholesterol itself. It's when it starts to embed in the endothelial wall, it's the oxidative stress that's actually causing the damage. Which you can control. Again, that's lifestyle things, diet, supplements, not smoking. So C-reactive protein. You want to talk about C-reactive protein? Me too.
Yeah, I mean, it's a substance produced by the liver to basically respond to inflammation in the body. It's a really useful test to basically just track or assess low-grade inflammation. And I think most bodybuilders are going to want to get this just because we know inflammation is a highly negative thing for cardiovascular disease, insulin sensitivity, in general circulatory function. But the problem with it is that it can be manipulated by so many different things: infections, a cut on your skin, and it only has like a 7 to 8 hour half-life. So if you 6 hours before a blood test, cut yourself or woke up and stubbed your toe and some shit like that, likely it will artificially inflate C-reactive protein levels. But I think for the spitting average, most people are probably going to be good when they go get it tested. I think it's a really good proxy to general inflammatory markers within the body. It's one of the proxies we can use. And usually you want it to be, if you're getting a high sensitivity C-reactive protein, which is my favorite test compared to just C-reactive protein, I think it's a number you want to be far below 1 if you can. Occasionally it's going to go above that because you're in prep, you're doing tons of cardio, you're training a lot. There's going to be just generally more background inflammation, but generally you want it below 1.
Cool. Yep. So I'm not going to bother with urinalysis stuff. If a doctor suspects that you have a urinary tract infection or possible kidney disease, they'll also look at your urine to just pick up, there's a bunch of different things that they can look at in urine for hydration and all sorts of stuff that's going on with your body. I think the most interesting part of this video that unfortunately we say for the end of it would be more the hormone stuff, right? That's probably what most people that are watching this would be interested in. So really the stuff that at least I'm looking at typically would be total testosterone, free testosterone, right? Total testosterone doesn't tell you a ton, but I still like to see what it is. I still think it kind of gives you a still overall view of what's going on in the body and kind of how someone is either if they're on drugs, if they're responding to those drugs and what is going on, or if their total is super low. Obviously, there needs to be some treatment there as well. Free testosterone, estrogen, E2 specifically for men. There are 4 estrogens. Men typically, you're just going to look at E2. Sometimes, depending on what they're doing, you can look at estrone, which is E1. That's rare. I do that on situational things. If people are using equipoise, boldenone, sometimes I'll look at estrone just to see because that can metabolize differently. Because you might see a crashed E2, but it's not telling you the whole story. Progesterone, I think, is interesting just to check if someone has mood disturbances or sexual issues. It's just good to get a range on it. It's very rarely skewed, but it is a very important thing. And the range is very tight for men. So it doesn't need it. It doesn't take a ton, but moving it a little bit can really affect a lot of things. I think prolactin is interesting to see. I think a lot of guys overvalue prolactin as a test. They blame a lot of sexual issues on prolactin. So prolactin is a hormone in women that causes lactation. In men, The only really known thing that it causes is latency between erections or ejaculation. Outside of that, we're not really sure what else it's doing. It is a good marker, though, to kind of test other things. But typically in men, the only time prolactin is elevated if estrogen is elevated. So it's generally the estrogen that's doing that, causing the misfunction to begin with, not the prolactin, or if thyroid function is low. So if you don't have an estrogen number, not that you'd ever just test prolactin without the others, but it can kind of give you an overall sense of what's going on with the other hormones. You know, it can also, you know, test for other like pituitary issues, but again, that's not super common. IGF is interesting to see. Again, I don't use it as a metric for bodybuilders. I know that everyone in the world seems to think that this is like the gold standard to see what's going on. It's not actually telling you that much useful because it's telling you what's in the blood that's bound, generally, whether it's bound and functioning or bound and useless. That's all it's telling you. What we care about is what's inside the muscle, and there's no way to see that without a biopsy. So I've seen guys that are absolute giants, monsters that have low serum IGF because the majority of it is actually going into their cells. And my IGF tends to run high. I'm not that naturally muscular, so it doesn't necessarily mean really anything. And people with giantism, the level is super high. It's much higher than you've ever seen on anyone on growth hormone. It gets, 1,000, much higher than you'd see like a 400 or 500 in a bodybuilder per se. What are the ones? I'm trying to think of what other. And DHT is similar too. So I would never personally waste my money on a DHT test because serum DHT is not telling you anything. It's just it's a waste product. Basically, testosterone has 3 fates in the human body. It's either going to stay as testosterone and function as such. It's going to be 5-alpha reduced, which takes place inside the cell. And there's more 5-alpha reduced in certain tissues that are more prone to having androgenic potential. And it's going to return to estrogen, which again happens inside the cell. So both serum estradiol and serum DHT are similar to IGF in that they're not necessarily telling you that much. They're just going to tell you what was spit out of the cell. So you can find, not that common, but sometimes you'll see a guy that has a low serum estradiol, but he still has estrogenic side effects. And the treatment actually, again, contrary to popular belief, the treatment still is to use an anti-estrogen because it's actually stopping the aromatase enzyme, which is inside the cell, from being active.
Interesting.
And DHT is the same thing. Testosterone has to enter the cell to 5-alpha reduce. The DHT that's in serum has been spit out and bound. And once DHT is bound to sexual binding globulin, it renders both sexual binding globulin useless, and it renders the DHT useless. So that DHT is not technically doing anything androgenic either. Is there anything else you look at or hormone-wise?
No, I mean, should we touch on ranges for those things? I don't think testosterone ranges are really important, and free testosterone doesn't really need a range necessarily if you're using enhancements. I mean, in general, theoretically, I think the differentiation that's important between total and free is that free testosterone is theoretically biologically available compared to total testosterone. But I think estrogen is important. Usually you want to see it in males, at least. I like to see it around 40 picograms per milliliter up to 60 to maybe 80, but even less than is fine. Some people function perfectly around 30 to 20 picograms per milliliter. Up as high as 60 is not really a huge concern for me. Once it goes beyond that, I'm starting to say, okay, maybe we should start to modulate this a little bit.
Yeah, I would say so. The way I would look at estrogen in a similar way to you is in a relationship to the androgen load, right? So we don't know, it's unknown what the estrogen to testosterone ratio should be in an enhanced athlete because there's too many variables. How can you predict that? In a natural athlete, we understand where the range should be, and that's where these ranges are established. I think if the androgen load is very high and someone is non-symptomatic, it's okay if estrogen goes up slightly above range. When it's above 80, to me, is absolutely doing nothing. I don't know what you're accomplishing there. But again, it depends on the person. I think just like anything else, it needs to be treated as a number and as an individual. I feel the best on my estrogen is between 29 and 40. So I don't really feel great when mine goes above that. Some guys might feel better when they're in the 60s. It just depends on the person. But again, that's an individual thing. So people understand. So you don't necessarily want, there's no anabolic reason to run your estrogen super high. You're not going to get anything more out of it being so high out of range. I know that everyone wants to run there's this new thing that everyone wants to run their super elevated. you're not going to look good or feel good either. And you're going to find sexual problems when it's super high. And you find sexual problems when it's also low. Crushing it is just as dangerous. But so again, I'll make an unpopular statement. There's more potential harm by having super elevated estrogen than there is from using an Arimidex. So Arimidex itself is not going to cause nearly as much harm or potential as having high estrogen. High estrogen in men is not a good thing. Where a lot of this comes from is anti-crushing your estrogen. So that's not what we're saying here. No one here is supporting crushing your estrogen outside of a bodybuilding show like peak week at the very end. In normal, you need some level of estrogen to function and for your health, but that doesn't mean it also needs to be elevated. And if you look at it logically, why would you want to look like you have high estrogen? It does. Even the common sense would, like, we all know what that looks like. Why would that be a look you'd be chasing?
Right. Yeah.
Right. You want to boobs and hips and hold water.
Right. Exactly. I think that too, what's important to state is like sexual function for men is mediated by estrogen more, I think personally, and from what I've seen, more than testosterone. And if you have a very small margin of error to make before you ruin your sexual function too low or too high. And so too high for a lot of people is above 60 to 80 picograms per milliliter. For me, kind of like you, I function perfectly at about 25 to 50 is like the sweet spot. And anywhere beyond or below is just like I'm a doormat, essentially.
Yeah. Well, I wonder if I'm just proposing something because I've never actually thought about it until you said that. I wonder if the reason why you and I function better at a slightly lower level is because we don't have a ton of body fat. So in order to get our estrogen at a 70 or 80, the amount of conversion we'd have to be using a ton of androgens that are converting at that point to get that amount in our blood, because we just don't have we don't have a ton of aromatase enzyme in us with lower body fat. So it's much easier for someone who's heavy to get to 80, an 80 estradiol than it is for you or I without having.
I mean, even on a gram of testosterone, my estrogen without any intervention is usually around 65, 70 picograms.
Yeah, mine might be lower. Yeah, so that's what I'm saying. So you'd have to use grams and grams of things, or dianabol or something that's going to be very harsh. Right. What you said about the sex thing is true. So the newest data on sexual function in men shows as long as testosterone is equated, meaning that it's stable across the groups. So we're not using that as a variable because testosterone is high or low. It can clearly screw up your sex drive. But estrogen seems to play the biggest role. DHT actually plays the smallest role in it, contrary to popular belief. And what occurs, again, if testosterone is stable and estrogen is high or low, you will destroy your sex drive and function as well, but kind of in a different way. The easiest way I can describe it is if it is low, you will have perhaps the drive but failure to be able to perform, right? And it's almost like it would be like prolonged ejaculation if your estrogen is very low until it gets low enough that nothing works at all. Right. And then if it gets high, you would be like premature ejaculation, like oversensitivity and premature ejaculation. Again, until then you can no longer achieve an erection. It breaks that way too. So you're going to break it one way or the other, depending if you're high or low, as long as testosterone's in the middle. But estrogen is hugely important with that stuff. So before, when I was talking about estrogen, I think people always misinterpret what I'm saying with estrogen. It's not that it's not important. It just doesn't make any sense to run it super high.
Right. Yeah.
And I see more of the consultation calls that I do, 90% of them are guys that have issues and their estrogen is always elevated. It's always high estrogen that's causing the issues. Yeah. No one ever thinks about this stuff.
Yeah.
I don't know if there's any.
And just the last, I think, important one to go over as far as ranges is prolactin. I think that's just the relevant one that people might need to test, which is 2 to 18 nanograms per milliliter. Again, I like to see it slightly lower than that top end and slightly higher than the low end, but generally, I think what's also important is, and you were almost touching on it, but prolactin also influences immune regulation pretty well. So if it's low, really, really low, because people are taking, like, abusing cabergoline or something, usually that is when you're going to get sick. And there's no secret as to why females usually get sick after they've had, I mean, this is like a whole other topic, but when prolactin's lowest in their cycle, right, in their menstrual cycle. So it's something that you want to make sure is in range, but it doesn't need to be checked very often. It's like usually it's going to be in range unless you're being a dumbass.
Yeah, I mean, and the reason why in females, at least, that it seems to be related to immune function, it's probably some sort of crossover to men as well. But in women, it's your immune system's stronger when you're lactating because you need to stay healthy in order to feed a child, right? And there was some sort of cellular crossover that occurred with men, I'm sure, with that immune function. Sure. Outside of that, I don't know why it would affect that in men, but it does. Yeah, but it's generally not. And with that cabergoline and those drugs, very rarely are those needed.
I never think they are. I've not had one situation come up ever coaching people where it's needed.
Yeah, and because it's generally not prolactin that's causing the issue, right? And the issues from those drugs are atrocious drugs. Long term. I mean, like dopamine withdrawal syndrome and all sorts of things that can go wrong with those. Right? There's cardiac issues from those drugs. It's funny because guys will say they're afraid of using an AI. They would gladly take caber.
Yeah.
Right. Yeah. Caber will actually harm your heart.
Crazy. Crazy.
Cool, man. Well, I think that was good. We could always, if people want to know more about any of these specific ones, we could always dive farther into them.
Yeah, there's so much we could talk about there. Yeah.
Yeah. Hopefully this helps everybody. But I always appreciate it, Colton. Thank you for coming on.
Yeah, of course.
Also, brother, I will see you soon.
Yeah. Bless your heart.
Take care.